Hi everyone, I'm Dr. Yang from Joint Shantou International Eye Center. Today I would like to discuss thyroid-associated ophthalmopathy with you. Before we start, I would like to thank Dr. Wei Haocai for the pictures. This is a picture of thyroid-associated ophthalmopathy, TAO, also called TAO. Doesn't he look like a famous character from Romance of the Three Kingdoms, Zhang Fei? TAO is also known as thyroid eye disease, TED, Graves' ophthalmopathy, or orbitopathy, GO. Its exact etiology is not yet clear. It's generally considered to be an autoimmune disease. Hyperthyroidism is commonly associated with TAO. However, 5% to 10% of patients are euthyroid. This photo shows the typical clinical features of TAO. The diagnosis of TAO depends on clinical findings, so let's go through them one by one. After this section, you should be able to describe the clinical manifestations of TAO. Let me start with the palpebral size of TAO. These are the most important features of thyroid-associated ophthalmopathy, including widening of the palpebral fissure, upper eyelid retraction, dilymphocyte, lower eyelid retraction, corneal side, and lid lag on downward gaze, von Griffith side. From the picture, we can see that normally the location of the upper eyelid is 1 to 1.5 mm below the superior limbus, and that of the lower lid is at the inferior limbus. In TAO, due to overactivity of Mueller's muscle and fibrosis of the levator palpebrae superior wrist muscle, there are both upper and lower eyelid retraction. And when the patient looks down, the upper eyelids cannot follow the eye. This phenomenon is called lid lag on downward gaze, von Griffith side. The second clinical feature is exophthalmos. Eyeball protrusion is the distance from the lateral canthus to the corneal apex. The normal range is 12 to 14 mm. We use exophthalmometer to measure this distance. In TAO, both increased protrusion and lid lag will be seen. This condition is called exophthalmos, and it's usually bilateral. For patients with hyperthyroidism, the symptoms of exophthalmos develop faster. In some patients, after hyperthyroidism is controlled, the exophthalmos will be reduced, while in others, it may become worse. So, how do we measure the degree of eyeball protrusion? We use an instrument called exophthalmometer. Thanks to my colleague Ms. Huang for taking this photo. There is a mirror with a scale. We put one side at the lateral canthus. Then we can see the corneal apex in the mirror and read the number on the scale. Now we will move on to eye movement disorders and double vision. Each eye has 6 extraocular muscles. When you look at an object, you are using several muscles to move both eyes to focus on it. If you have a problem with the muscles, eye movement is restricted, resulting in strabismus and double vision. Normally, when the eyeball moves in different directions, the inner margin of the pupil can reach the upper and lower tear dot connection line. The outer corneal limbus reaches the outer canthus. The lower and upper limbus reaches inner outer canthus connection line. In TAO, extraocular muscle involvement is inevitable. In the early stage, there is edema, infiltration of inflammatory cells. In the later stage, the muscles end up with hypertrophy and fibrosis, as we can see from the orbital CT scan, which results in eye movement restriction and eventually causing strabismus and double vision. In TAO, there is soft tissue edema in the orbit, and the increased orbital pressure leads to conjunctival edema and hyperemia. also shown in the orbital CT scan. In serious cases, the conjunctiva protrudes beyond the lids, and the eyes cannot fully close, resulting in exposed keratitis or even corneal ulcers. Optic neuropathy is a secondary change. In TAO, the intraorbital edema and increased orbital pressure causes optic nerve compression. Papilledema can be seen in the early stage and pale atrophy in the late stage. It will cause visual acuity and visual field loss. Sometimes it's associated with retinal edema or exudation and tortuous dilation of the retinal veins. So, next time if you meet a patient who looks angry and a bit like Zhang Fei, you should give him an examination to see if he has the following clinical eye size. Palpebral size. If there is any widening of palpebral fissure, eyelids retraction and von Griffi side. Exophthalmos. Measure the distance from the lateral canthus to the corneal apex. Eye movement disorders and diplopia. Ask the patient to move the eyeball in different directions to check for movement restrictions and double vision. Also, examine the conjunctiva and cornea with the slit lamp to check for edema or redness. Lastly, look at the status of the retina and the optic nerve. These are my references. Thank you for your attention.